Namaste. I want to thank Shashiji. I lived in India for a few years. I can say a feji words. And Ramaji and Shaliji, of course, for inviting me. It's an honor to be here. I lived in India for about 4 years, back in the 80s. I got free education, so whenever people talk about India, I want to do something because I got free education. So here I am. I'm honored to be with you today. As you can see from the clip, this program, the community health worker that I'll be sharing with you, is a kind of a model we adopted from Iran, and I'll just walk you through the health stats in the United States, actually, as well as in Mississippi, and then and I'll talk about some of the accomplishment and the challenges. Are you going to change it or did you change it?
Yeah,
okay.
You want me to go next or stay here?
Yeah. Yeah. Next slide, please. So, as you are aware, there has not been political relationship between U.S. and Iran for over 35 years. And when we started talking about, okay, we are going to borrow some element from Iranian community health worker system, it was immediately caught by the media. The Los Angeles Times wrote, in a toxic environment, some people are trying to do something. Toxic political environment. It was also picked up by Al Jazeera. You saw a clip. The American Association of Retired Personnel wrote about it. It was featured also in New York Times Magazine in 2011, just because how these countries who don't have relationship, they can work together well, they can put politics aside and do something good for people. Okay, next one. Next, please. That was a clip. Okay, when I talk about this issue, I don't know who my audiences are, so I want to just explain a couple of terms. How do we compare, for example, one country is healthier than another country, one group is healthier than another group. We go over some indexes. For example, life expectancy. A person who, in a number of years, a person is expected to live at the time of birth. That's life expectancy. Infant mortality rate, how many kids die in 1,000 before they become 1 year of age? They come out. So that's life expectancy. Child mortality rate, how many children die in 100,000 before they become 5 years of age? Maternal mortality rate always dead because of the reproductive stuff. That's maternal rate, and morbidity and mortality means number of people who are sick or number of people who die in the population. So those are just some basic terms in public health we use. Okay, so this is it I think there's a light here, hopefully, right? Yeah. I have one, I didn't need to. So, we are living in a very rich country, but we are spending this much, United States and more, in all the industrial countries, advanced countries, actually, we are spending the highest amount, close to 8,000 per person, but if you list all the countries, when you look at those health index, we don't even fall in the top 10, and I'll explain why it is the case. Next, please. This is what, if you look at these, infant mortality rate, life expectancy, all that. So US, all other countries spending less money, but the life expectancy is 76. That's one indicator that we are not as healthy as other nations. Next, please. We have been spending the 16 to 70% of GDP is going up and up, but still we don't see the results. So we are behind other countries. Next, please. In Mississippi, for example, starting from 1995, there are millions. Cost goes up, but still we don't see the outcome in terms of health outcome. Next, please. So if you look at Mississippi, Mississippi has about 3 million population, 53 lives in rural areas, poverty rate highest in all the states. It ranks last in all the states. Teen pregnancy is high. We know with teen pregnancy, mature babies and all kind of health situation. And then Delta region, which is the rural area of Mississippi, basically has the highest power, and also most African American actually live in Delta. Next, please. So countries with highest poverty rate have high average percent of African American. That you can, people say, racism is over, but when you are in Mississippi, I always say that the racism really is live, and unless we address racism, hidden racism, there's no way you can actually address health status in Mississippi, at least. Next, please. So, over the all these years, we have been always at the bottom of all the states in terms of health indicators, health status. So only recently, we are called the fattest state, and only recently I saw that we have jumped up 1 or 2 states. But overall, despite the fact that we are spending so much money, but still health is not as good as supposed. So we have the high rate of obesity, high rates of the diabetes, high rate of infant mortality rate, high rate of stroke, chronic disease, poor nutrition, reduced life expectancy. So what do you do if you end up as a public health professional in India and trying to be sensitive? You get grant, you go to rural area and say, okay, it's great that I can actually publish papers, get some money, get by ranking, but what is the staying for the local people? That's what happened when I had an NIH grant, was doing research in the rural area. I said, okay, once I leave this place, nothing is going to change. So I started kind of talking to Dr. Shirley that you saw in that picture. We lost him last year. I said, Dr. Shirley, something needs to be done, because he was the first pediatrician, African-American pediatrician in Mississippi. I said, we are spending this money. I go there, I see people suffering. What needs to be done? He said, well, what do you suggest? I said, having born and raised in Iran during my childhood, I saw many babies without mothers. And each time I would ask, my mom, why these babies don't have mother? Well, she said there was something kind of a invisible being comes and steals the mother's liver during the delivery. Well, I wanted to become educated, and so I can figure out what that invisible being is. It was bleeding. Mom would die because of during the delivery, but they found an explanation. The explanation was found for it to explain why moms they died. So with that, I went back to Iran in the 90s, and I saw that those numbers are not, I don't see too many babies without mom. I don't see too many orphans. And then I asked, people what's going on, what happened. They start talking about health houses. In fact, I had a project on night blindness with UCLA, and I was going from village to village, and I look at these villages in a very, very far distance, and I still only one baby died last year or the day before, and I'm going, what's happening? So I start really interested in, start kind of showing interest in health house, which I will talk about. So that's what I said, Dr. Shirley, would you like to go to Iran and see, how they reduce the infant mortality rate and health situation in Iran? So sure. So next, please. So that also shows it in Mississippi that in fact the infant mortality rate in the nation is 6, but in Mississippi it's 8.8, but actually in Delta it's almost 14. Now this is given the fact that many babies are actually kept in incubator for a year. It costs $1 million to keep them alive. Otherwise, really, that would be that infant mortality rate would be much higher in Mississippi if we did not have the technology, science and technology. Next, please. So this is the kind of a picture in Mississippi. So you don't have insurance. You don't go everywhere. You don't go for a checkup. But when you get sick, you go to hospital. And by federal law, the hospital, they have to treat you, right? So the hospital cannot sustain. Because you go there, the hospital loses money, eventually it closes down. That's the case in many community hospitals. They're closing down in Delta, Mississippi because of that fact. Next, please. So what do you do as a public health professional? You see there's something then. So I discussed with Dr. Shelley. We ended up going to Shiraz in Iran in 2009. Of course, it was difficult to get visa and all that, but we arranged it. I learned that the Iranian, after the revolution, they wanted to, basically provide services to the villages. And the way Iran is, that because of this geographical situation, you don't have villages like connected to each other. Every 40 to 50 kilometers, you have a village. So how can you actually provide services to, a situation like that? So Iranian, after the revolution, they got together and said, we want to come up with a plan that would provide services to the villages. Some of you may know that the barefoot doctors concept back in the 1950s in China, the community members would be trained to provide basic services, distributing malaria pill or something to the community, and then Thailand picked on it. So the idea of community health worker has been around, but never in kind of a systemic way through a government approach. So that's what the Iranian did. Basically, next please. Go ahead, I think we want to know much about Iran. I want to talk about the system. Next, please. Okay, so this is the picture from Iran earlier. So you can see that the coverage was pretty much negligible. Life expectancy was 55. These are, in the rural and also in urban area. Infant mortality was high, but if you come to 2009, you see that, coverage has gone up, life expectancy has gone up. You see that population growth was reduced from 4% to 1.6% because community health workers played a major role in that. Maternal mortality rate reduced, and infant mortality rate. So this was very interesting to World Health Organization, and Iran was rewarded for that effort. Next, please. You can also see here, kind of, graph how things have reduced, urban and rural area, the differences. Now they are almost same. So if you can actually use cheap community health workers to accomplish that, but you've got to have a policy in place. You've got to have political will to do it. Next, please. So this is what Iran did. They mapped the entire country. So these are the health houses, and they built a health house in each village. And then they recruited a male and a female from the village. And those days, in the 80s, there was, in some villages, they could not even find a 5th grade female. So, and then they built this health house in such a way that it would be only 1 hour walking distance to the rural health center. So here you have a health house, 100 square meters, with a room, waiting room, examination room, and a room for the community health worker to stay. And then those male and female, because of culture, culture appropriate stuff, they train females so that the female will train, will deal with female, and male will get on the motorcycle and go and check the water source and the butcher shop to make sure that the food is, is safe. And then they connected several of these health houses to a rural health center. So in the rural health center, you have a physician. By the way, all medical education is free in the government institutions. So in order for you to get your license to practice in private sector, you have to actually spend 2 years in that rural health center. That's called policy, that's called political will. So you train physicians, but you say you cannot go and open your private clinic unless you serve 2 years in that center. So you have a physician there, you have a nurse. So the community health worker is trained. I will discuss how they are trained and what they are trained on. So they, the community health workers, they have a file, the folder for each health house. They map a village, exactly they know how many people live in the village, what kind of medication they are, pretty much, because they are part of the community. Those villagers, they are their uncles, cousins. When a baby is born, they don't wait for the baby to come to the health house. They just go there and say the baby needs to have vaccination. And so they schedule actually patients who needs to be seen by these physicians in the rural health doctor comes down, weekly or bi-weekly or monthly. But regular patients, they are sent to rural health centers. So let's say a female who is suffering from high blood pressure will be sent there, but they will not deliver the baby there. There's an ambulance there, and this is connected to the district hospital. District hospital is connected to the university. University is connected to the Ministry of Health. So there's a kind of a loop. All these community health workers, they come here for training every month. They exchange data, how many babies were born, how many babies died, who got vaccinated, and then they also get some continuous education from rural health center. But there are also, if the villages are too small, instead of having a health house, and they have some navigators, they are called, they train community members, so they actually work in conjunction with the health houses. So they put these places, and it has really made a difference. They reduce the infant mortality rate, they reduce reduction in childbirth, and overall it has really had made a great impact. Next, please. So the health house, I already explained, is a place, that's a small place in a village, staffed by community members. Okay. These are some of the things that the community health workers, what they do, they are called behbaz. They take census, they take health education, maternal child, family planning. These are some of the things that I can discuss during our break time, because I think I'm showing fingers, so there's time. Next, please. And key factors for community health worker program success is community-based, is cooperation among community actors, community health workers recruited and enthused by their own community, continuing education, compensation is provided, because they are all over the salary, they are paid, careful supervision and monitoring, and commitment of all actors involved. In other words, Ministry of Health, Ministry of Education, all various actors. So this is essentially what they made it. Community health house, you start from community health house if you need to go to a rural health center, if you need to go to hospital. In the Iranian experience, only 20% of people ended in hospital. 80% are actually dealt with at these two levels. Next, please. So basically, we got the idea from Iran. Next, please. Americans, they visited Iran. We had an MOU, the first MOU, Memorandum of Understanding with Shiraz University. So we visited there back in 2009. Then we invited the Iranian to come, and then we also involved the NIH and World Health Organization people. These are some of the ladies that I took from Mississippi to Iran. In fact, there's an island on Gulf, on Persian Gulf. So instead of having to hassle with visa, we would fly to Kish Island, and then the Iranian would bring their trainers and everybody, and people would say, "How do you go to Iran?" I said, "I have bought an island." So, and this is when we trained the first group. They got their certification by the former Minister of Health. So what we did, we said, okay, the people we took to Iran, we kind of trained them. We wanted to see if it's really working. So the initial phase, we had about 470 people assigned to those community health workers. Next, please. At the national level, there is about 25% return to hospital once we discharge patients, and now there's a law that actually it's kind of stopping that. We reduced that into less than 5% in a matter of over a little bit a year. Okay, thanks. Then what we did, I applied to Center for Medicaid and Medicare as federal grant. I got a federal grant. For the past 2 years, we trained some community health workers as a pilot project, and just last month the project ended. So we are now in the process of assessing. Next, please. I just took that thing from the database I have. So we had about 300 participants. You can see that some of things in 205, the people who are paying this much money in the hospital, actually they are not this. This is most important to me, that they did not go to emergency room for non-emergency reasons. See, not only that you're having reduction in cost, but also people are not going, that's a huge save. Now that's one component of it. The other component is that we are actually interviewing the community members who participated to see what stories do they have to take to the community health workers, how friendly they were, how, because community health worker would call them and say, today is your appointment, today you need to take your medications, you need to do this. So we don't have to really have a specialist to deal with small stuff. We were discussing earlier, World Health Organization has this report about social determinant of health. In fact, 80% of people's health outcome is not because of their gene, it's not because of their color or gender or what, it's because of the environment, it's because of their education, it's because of lack of access to healthcare, or maybe a lack of information, insurance, even their, belief what food eat and what food not to eat, socio-political, economic system. So if we can address those social determinants of health, we don't have to spend lots of money at the end for treatment. So in this country, primarily we are spending lots of money. For a long time, I had a penny on my office saying that we spend only a penny of a dollar on prevention. And we spend most of our money, 99%, on diagnosis and treatment, and that's what we'll get that picture. But with the affordable care, now we're shifting a little bit to prevention. There's also Healthy Because 2020 is a mandate for the next 10 years. There is a little bit shift in emphasizing prevention, but unless we do emphasize on prevention, there's no way we can actually change the all health outcome to the United States or the Mississippi. Next couple of more slides and I'm almost done. So I'm dreaming to have this kind of system in place in Mississippi and hopefully beyond. So you have health houses, then you have community health wards, care centers, and then hospitals. And this part is really health education and prevention. Next, please. So sometimes people ask me, what's the driving force behind this? There was a Sadi, it was a Persian 13th century poet, and actually his saying is in New York. So I'm just going to recite in Persian. It may just sound nice in your ear. And then the next slide is the translation. It says, Bani Adam اعضای یکدیگرند که در آفرینش یک گوهرند چو عضوی به درد آورد روزگار دگر عضوها را نماند قرار تو که از مهنت دیگران بیغمی نشاید که نامت نهند آدمی. So, next slide, this is a translation. Human beings are members of the whole in creation of one essence and soul. If you have no sympathy for human pain, the name of human you cannot retain. So that's the concept of what can we do together in order to help people who are suffering from the things that they should not be suffering. Understand?
I exercise my prerogative as a moderator to let the story be completed because it was a fascinating story. And I hope you found it so. And in that last slide, I hope you saw the echoes of that song that was sung at the end of the movie Gandhi. Remember that song? It's the exact translation of that. What other proof do we need about the oneness of all of us? Anyway, questions from the audience? We have about a minute or so left. If you have questions, we'll take one, maybe two. Otherwise, we'll move on to the next speaker. Yes, please go ahead.
Thank you for your speech, Bill. So I'll follow up later on the MOU. The question is, like you mentioned, we spend a penny on prevention per dollar. Is that from World Health Organization or from the United States?
No, that's the United States. That was the United States. That was a symbolic thing that we are not spending too much money on prevention. We're spending too much money on treatment. Simple things, for example, there's a little device actually you can prick your finger and know if your sugar level is normal or high. So if you do that, you know that sugar level is high, then you manage it, right? But if you don't do it, what happens after a while you end up at hospital emergency room, they say, oh, your kidney is not functioning, now we have to connect you to dialysis machine and all that. So everybody's going to make money. Even to some hospitals, they actually have contract with physicians. If you don't see so many physicians, your contract is not going to be renewed. So I understand it's a capitalistic country we have, we want to make money, but Somebody needs to do something.
Yes, one more.
Extension of that question. Is it ignorance of the public or negligence of the state and federal government?
I'm sorry?
Is it ignorance of the public or negligence of the state and federal government?
It is the interest of those who want to make more money. And they are impacting the policies so that we don't have prevention. That's people who want to make money. I think that, I'm just strong to say what I feel, you know.
Thank you very much. And once again,
I'll be around during the break time. I'll be glad to chat with you and answer your questions.
So I think that was very amazing that we're going to Iran to learn how to improve our health system. And nobody would ever have thought about that. So actually the world is one, and it's where, and it's amazing that Dr. Mohammed here managed to convince Mississippi to do that. So, and it's amazing that Mississippi took it on. So I think we have a great admiration for both of them. Next speaker is going to be Dr. Thakur Patel, and we're going to have Ms. Trishna Dev moderate. So I'll bring up Mrs. Trishna Dev to start next.
Let me correct you, Sunil. It's Trishna Dey, D-E-Y. I think they left off the tail. That's how I got a new name now.
Like I said, anybody, if I don't say it correctly, please correct me. So the rest of the people.
If my husband was here, he wouldn't like that. But my name again is Trishna Dey, and I do believe a lot in prevention, and public health is my focus. Unfortunately, I did not finish my medical degree, but I've been very keen on anything related to healthcare, and I've been working over 20 years in the US in different aspects. But now, in the last 3 years, I had the privilege of being in India and working in a cancer hospital. A cancer hospital donated by Mr. Tata, whose mandate was 50% of the patients were going to be treated free or subsidized, which was a challenge. And it was a new place, and I was given the mandate or the role to introduce patient navigation. And that is to address the barriers to treatment. And patient navigation, there, I said it has to be an India-centric model. And the biggest barrier to treatment was financial, because they had patients from both ends. We had patients who were paying, and the patients who were not. And this was a state-of-the-art hospital with all modern amenities, equipment, name it, and a beautiful premises. So this was quite a challenge. However, we did come up with a solution to see how we could pick the ones who were really needy. And unfortunately, it was focused on cancer. This, we're talking about health in general. But I just wanted to relate to you that we came up with the matrix, and we came up with a lot of counseling and interviews with the patients to pick up the ones who are really needy. Because unfortunately, if you go back to India after a long period of stay here, you don't expect India not to have changed. For me, for instance, a cell phone was not an asset anymore. Everybody had a cell phone. So we had to strike that off, because when we made a list of all the assets, like a goat, cow, cycle, anything that comes from the rural areas, we had to strike off cell phone, because everybody had one. So we can't not accept that fact. However, so we did come up with a matrix, and unfortunately we had a good donor fund for this, to treat the patients, which was amazing. And I had a lot of people from California come and see, how are you all doing this, managing both? No community hospital. It was the same premises taking care of both types of patients. So it is a challenge, huge challenge. The director found it, he found out the ways of doing it, but I'm not going into that anymore. We're already running late, but I'm very keen on prevention. That's what I saw the gap. People, even the doctors, didn't want to deal with prevention.